Okay, so good morning, everyone. Welcome to this Track B Symposium session. Transgender populations connecting the dots for trans clinical care services and HIV care. My name is Dr. Nitya Panupak, and I'm the Chief of Prevention at the Thai Red Cross AIDS Research Center. And I will let my co-chair introduce herself.
Good morning, everyone. My name is Alicia Krieger. I work at Department of STI, HIV and AIDS and Viral Hepatitis of Ministry of Health of Brazil. I am a pharmacist doctor too. So let's start our session. Dr. Nitya, please.
Yeah, we have 4 speakers today, and everyone has promised to give you the best information, knowledge, and experience to share with all of you around the clinical care for, I think that would be both HIV treatment, HIV prevention cascades. And our first speaker is Dr. Arent Wilson. Dr. Wilson is the Senior Research Scientist at the Center of Public Health Research at the San Francisco Department of Public Health. She is also an assistant professor in the Department of Epidemiology and Biostatistics at the University of California, San Francisco. In this talk, Dr. Wilson draws on her qualitative and mixed methods of on HIV prevention, care, and intervention research with trans community for almost 20 years. She's currently the co-PI and of the International Perspective HIV Incidence Study of trans women in 4 countries. Dr. Wilson has also conducted HIV research in Brazil and Nepal. She is also the PI of the evaluation of a special projects of national significance to increase engagement and retention in HIV care among trans women of color. Please welcome Dr. Arent.
All right, welcome everyone. It's so wonderful to see so many friendly faces of colleagues and friends here today. Thank you for coming. So the title of my talk today is Gender Affirmation in HIV Care. What I really wanted to go over today is some of the local data I have from the San Francisco Bay Area and a larger initiative working with trans women of color living with HIV. So we get just kind of a broad sense of what we've seen so far in interventions and in research are the needs to kind of fill the gaps in HIV care outcomes for trans women. So no conflicts of interest that I know of. So thanks to our colleagues at Hopkins who did this fantastic systematic review showing that 19% of trans women in a systematic review pooled prevalence were living with HIV, so extraordinarily high HIV prevalence in this community. And just to bring it to the US, to contextualize the data I'll be talking about, in the US, trans women have a 34-fold greater odds of HIV infection than the general US population. So again, extraordinary HIV risk in the US in particular. And to bring it very local to my hometown in San Francisco, we estimate that around 40% of trans women are living with HIV. So there was some great data put together from our medical monitoring project that showed that about 1.3% of folks in the US that are receiving HIV care are trans women. And the data was great because we could compare to non-trans men and non-trans women. And the paper by Mizuno et al., we found that trans women had less adherence and also less viral suppression. And what was really interesting to me was that a lot of folks were not actually accessing supportive services and even what they categorize as basic services such as food and housing. So we have a lot of disparities even within HIV care for trans women. So I'll talk a little bit about data. Our TEACH study is our trans females empowered to advance community health study. We started doing surveillance with trans women around HIV in '99 and had a big gap and started it up again in 2010. And then we followed up in 2013 and 2016 as part of a larger international study to understand prevalence over time among trans women. So I'll talk a little bit about those data and also data from this incredible project that was funded by our federal government called a Special Project of National Significance. And my local project was working with a small community-based clinic in the East Bay, and it was called the Brandy Martell Project. Okay. So here's our cascade in San Francisco. So looking at surveillance data from TEACH 2 and TEACH 3, so 2010, 2013, and 2016, you can see big increases between 2010 and 2013 in particular around linkage to care, whether folks are on HIV treatment and whether they self-report being virologically suppressed. So these are excellent. This is excellent in any scenario, especially in the US. However, we do see this big gap in viral suppression for trans women, and we are a 100% treatment access city. So one of the reasons I think we see this big bump from 2010 to 2013 is because we established a policy in the city of universal treatment access. So all folks should have access to HIV care in San Francisco, and we also are really lucky to have 5+ clinics that provide trans-specific healthcare, which is really extraordinary. So even in a situation where trans women have access to trans-specific healthcare and HIV care, we still see a real gap in trying to get to that 100% viral suppression. So my question really is having HIV care and trans-specific healthcare enough? Is that going to get us there when working with trans women living with HIV as far as having kind of perfect HIV care outcomes? And I really want to start with, all right, so what are the issues, and starting with who are most impacted by HIV in San Francisco in the trans community. What we find, this is kind of a graph showing our census data compared to our HIV cases and then our cases of HIV among trans women looking at race. As you can see, all racial ethnic minority folks are disproportionately impacted when it comes to HIV in the trans community. And that's really where we need to focus in San Francisco, and I suspect, based on some data we've collected in other countries as well, that's where the focus will need to be. And the beautiful thing about this is that we have pop size estimates in San Francisco showing that our community there is probably about 3,000 trans women, and about 40% of those are probably living with HIV. So we have an incredible opportunity to wrap our arms around these less than 2,000 people and get them completely virally suppressed. And given the resources we have in the city, both on the HIV and trans access care side, there should be no reason why we can't do that. So this is the perfect paradigm, and what do we need to do going forward? So the good news is, in TEACH, we found that those who are in care are virologically suppressed, so that's excellent. Care works. We also know, we have some data showing that those who are on hormones as kind of a proxy of access to trans-specific care, they also report having a higher viral suppression compared to those who are not on hormones. So care also works. It's very important. And then I'm going to talk a little bit about our data from our Trans Women of Color HIV Care Initiative. So in 2012, 9 demonstration sites around the US were funded to provide interventions on top of their existing trans healthcare and or HIV care services. So all of these organizations and these initiatives were had a long history of working with trans women and trans women of color to address their HIV needs. So they were very trans-specific, very HIV care oriented. And I'll talk a little bit about our Bay Area sites. So we had 2 clinics and 1 social service provider. Go forward. Okay, so just to give a sense of who were in our Bay Area data, most of the folks in our study throughout the Bay Area, about 70% of them were African American, trans women of color living with HIV. About 20% were Latina, and fewer than that identified as other ethnicities. So all trans women of color. And just to give a sense of what are their barriers. So they were not virologically suppressed. They were struggling with retention, struggling with engagement in care. And when we look at what are their life circumstances, we found out that in our Bay Area group, about 66% of trans women were precariously housed. So they lived in single room occupancies, they were couch surfing, they were homeless. So extremely unstable housing. We also found real lack of opportunity. So 40% of them almost had less than a high school education. So their job opportunities were extremely limited. And it was no surprise to find that almost 80% of them ran out of money in the last month more than 2 times. So they did not have a dollar in their pocket to get by. And again, no surprise that almost half of them had engaged in sex work in the last 6 months. So extremely vulnerable group of folks. Again, and then 15% of them were incarcerated in the last 6 months. So extreme structural challenges. And they also faced the systemic discrimination. So almost a quarter of them experienced some discrimination in shelter, in housing, in jobs, even discrimination from their doctors, they reported recently. And we found these data extremely surprising because, again, all of our Bay Area providers were very sensitive to the community. They were experts in HIV care, and this is not a representation of the experiences with the physicians and doctors that worked in our initiative, but what trans women of color's experiences were in the medical system. And as you can see, a ton of them did not even trust their doctors. They thought they were suspicious of modern medicine. They felt like they couldn't confide in their doctors because it will be used against them. So a lot of trauma in the medical system that really was carrying over into our initiatives and the lives of the trans women we worked with. Thank you. Our folks that put together the larger initiative, the 9 sites, it was 861 trans women of color participated across sites, which is incredible. And I think what's interesting here when we look at retention and care, you can see that discrimination and sex work were negatively associated with retention and care. The plus here is that currently in hormones, so those who were on hormones had a higher odds of being retained in care. So again, care is important as far as trans-specific care. And then not everybody had a viral load test in the last, at the last test, but of those who did, being unstably housed, not having transportation, not having social support were all linked to poor outcomes in terms of their viral load. So they were detectable or reported being detectable. But again, those who were on hormones were more likely to be virally suppressed. Okay, so just to kind of wrap this up, as far as what are the barriers to what's going to get us to that final 100%, we do, as public health providers, whether we want to or not, whether this is our expertise or not, we have to address systemic discrimination, both towards people who are trans, to identify the intersectionality of racism and transphobia, and also HIV stigma is hugely important. So we need to really tackle discrimination if we're going to get further in having better health outcomes among trans women living with HIV. And again, another big challenge for all of us is we have to address economic inequality and housing instability, income, education. Folks need opportunities, and if they don't have them, they have to focus on their survival. And if they're focusing on their survival, they cannot focus on their HIV care. And a lot of folks, we found a lot of trauma within our participants and a real lack of trust and support. And so we need to be really cognizant about how we provide both our trans-specific care and our HIV care to address these issues related to trauma and trust. And I thought it was really interesting when we think about who are the women we were working with. One of our sites actually found that 22% of their trans women of color participants were the highest medical utilizers in our healthcare system. So the folks we were working with were accessing all the services as much as they could and still not really making any headway in their care. And they really needed all these services. So in our national data showing folks aren't accessing or able to access these services, it just shows in many different ways that we need to be providing those ancillary services beyond care. All right, so what did we learn? Within the clinic, there's still some work we can do. Trans-specific services are important. Our data show it. Our participants report it. So that is a good strategy, providing trans-specific care. But we need to really be multidisciplinary and co-locate services. So we've had a lot of success with case management, peer navigation. Mental health and psychotherapy is absolutely essential. And social work if possible. So all of these need to be integrated. They can't be separate. We can't send referrals. We have to have them in our clinics. And retention was absolutely essential. So giving someone an appointment card and hoping they're going to show up 3 months later is just not going to work. So almost across every intervention, folks had ways of bringing people in for workshops or drop-ins or other things in between visits so they could keep in touch with them and provide little carrots for them to come in for their care appointment. We really have to address the fact that our folks are really highly traumatized, and we need to have services that match their level of trauma and acuity. So one of our intervention sites, they had every visit was 4 or 5 hours, and those were interim visits, not just care visits. So it's intense, but we do have this community that we can wrap our arms around and make a difference by providing accurate and the right kind of resources. And innovation, one of the site I worked with actually had a legal clinic. We thought we were going to help folks get in care by addressing their legal issues, and we thought it would be a lot of criminal charges like solicitation and whatnot, but we found that a lot of our cases were civil, and having an attorney that could address what were relatively simple cases around personal debts, car warranties, landlord-tenant issues, opened the door to folks having access to housing and health insurance, transportation, and then they had time, resources, and the mental space to actually attend their care appointments. So I really encourage folks to think kind of outside the typical public health box, and I just wanted to provide a little quote from one of our participants as she was talking about how her legal services helped her, and she said, I've been trying to stay positive. It just wasn't fair. I've always been a good person. I didn't want to do nothing. I didn't want to go nowhere. I just wanted to die. I kept getting knocked down. I couldn't get up. I had no aspirations. I didn't have no one but my friends at Tri-City. It was all Tri-City. So when we supported her and helped her access her legal services, her getting that justice helped her maintain her engagement in care. So what do we need to do? We need to do advocacy. A lot of our sites across this initiative did a lot of internal training, which was absolutely essential because there is so much turnover in our organizations. We need to provide case management and other services to address housing, income, employment, and legal services. And we do need to do better around trauma-informed care, provide gender-affirming care, provide mental health services, and address medical mistrust. And trans-specific care is absolutely essential and important. And that's it. Thank you.
Thank you so much, Dr. Arent. So now we have another speaker. I would like to introduce Dr. Gail Newton. Dr. Gail Newton is a clinical professor at the University of British Columbia Faculty of Medicine, consultant psychiatrist at Vancouver Coastal Health and Provincial Health, and chair of the BC Trans Clinical Care Group. Dr. Goodson served as a co-chair of the DSM-5 and ICD-11 consensus committees for the World Professional Association for Transgender Health. Writing group member of the Standards of Care for Transgender Health version 7. And she is the co-chair of the WPATH Global Education Initiative. After having completed terms of Secretary, Treasurer, and President-elect, Dr. Newton currently serves as President of WPATH. She is founder and former President of the Canadian Professional Association for Transgender Health. She is also held leadership position within the American Society for Reproductive Medicine and International Society for the Study of Women's Sexual Health. Please, Dr. Gail.
Thank you. I would like to thank you for inviting me to this session, and I also would like to say hello on behalf of the Board of Directors of the World Professional Association for Transgender Health. How many of you in the audience have heard of the World Professional Association of Transgender Health? Oh, fantastic. Close to half. That's amazing. Okay. Usually when I'm talking in audiences that aren't directly related to transgender health, usually about 20% of people have heard of WPATH, so it's very encouraging that we're getting our word out there. And so when I look at the audience here, we're up to 50%. So hopefully with our education initiatives that we are starting, that number will increase. And today I'm going to talk to you about our education initiatives and invite you to contact us because we would like to partner with you to do more transgender health training. And as Dr. Wilson said, that the more people are trained in transgender health, the more people are able to access transgender health care globally. So I'm just going to speak briefly about WPATH. The panel had asked me to talk about gender dysphoria-related diagnoses in DSM-5 and ICD-11 and how this is changing access to care. A bit about our standards of care, which is our healthcare document that we produce, and also about our global education initiative. So WPATH was formed in the late 70s, and we are the only organization in the world that is devoted solely to transgender health. We're an interdisciplinary association, and what we're most known for is developing the standards of care. We currently have around 1,800 members, and just within the last year, we've instituted a tiered membership type of system based on the World Bank rankings, and so depending on what country you are in, the amount of membership is tiered. The other initiative that we've had within the last 2 years is a student initiative, the WPATH student initiative, and now the student memberships are $35 US. So I would encourage you to go to our website, which is www.wpath.org, and join. And especially I'm encouraging the students to join because we have a very robust student program. So WPATH has been involved in a number of different projects and consensus projects. And so we were asked by the American Psychiatric Association to comment on what was then the draft version of DSM-5. And so we struck a consensus committee of people that were the senior academics and clinicians in the field around the topic of gender dysphoria. And so at that time, in previous versions, it was gender identity disorder, but the academics in the field and as well as the clinicians said that the person's gender identity is not disordered, but sometimes people feel there's a gender dysphoria or a distress from the sex that they are assigned at birth with their gender. And so we put this proposal forward as well as other committees, and it was adopted by the DSM-5 committee. So the other project that we were involved with was we were asked to comment on the ICD process. So again, we gathered experts from around the world to look at diagnoses around gender dysphoria. So in the ICD-10, one of the main diagnoses is transsexualism, and we recommended that the name be changed, and also that it be moved out of mental disorders. So we had hoped that we could have a separate chapter related to gender incongruence, but there wasn't that would only be one. There would only be one diagnosis in that chapter. So what happened is that it went into a chapter called Conditions Related to Sexual Health, where the different sexual medicine diagnoses are related. So this is in beta form right now, and the comment period was supposed to end at the end of June, but I see that the comments still are open on the website of the ICD. So if you just look at beta version ICD 11 and go on there, you can comment on the inclusion of having gender incongruence in the sexual health chapters. So I think that this is a really, really important move out of mental disorders, because we want people to access care, transgender people to access care, but we don't want it associated with a mental health disorder. So this will leave it in the ICD in a chapter related to sexual health, and then hopefully when we look at a subsequent version of the DSM, hopefully DSM-6, or I don't know if they're going to do 5.1, 5.2, then if we have gender incongruence in a chapter outside of mental disorders, what the goal is that gender dysphoria will not be included in DSM-6 because we will have it within the ICD. So those were two of our major projects that we had been working on over the last 4 or 5 years. And the other project that we have been working on was the 7th version of the Standards of Care. The first version came out in 1979, and this version came out in 2012. And so this has been translated into now 15 different languages, and it's available free for download on our website, WPATH.org. And so this will always, the board is very adamant about the standards of care always being able to be free for everyone, and that is free to access. We're embarking on having a new website. Hopefully it'll be done by the summer, and with that we'll have a better kind of mobile website that this will be able to be downloaded more easily. Having said that, I'm really excited that we're starting the next version of the standards of care, and we have our new co-chair on the state who I'm presenting with today, Dr. Asa Radux from New York, and Dr. John Arcelis from Nottingham, and Dr. Eli Coleman from University of Minnesota. So these co-chairs were actually appointed last week, and so we're very excited about embarking on the Standards of Care version 8. The release date will be November 2018. In the first week in August, or the second week of August, there will be a call for people to join the work groups. So I encourage people here to apply to join. There will be approximately about 20 to 25 chapters in the new Standards of Care, and we will be asking people to apply to the different chapters. These chapters will, you'll know what the chapters are. And also we have stakeholders for each chapter, because we thought it was very important to involve the community as experts in their care. So that'll be coming out in August, and we hope that we will have all of the groups together working by probably early October. The other thing that was really important for us in this new version of the Standards of Care is to have a more evidence-based approach, because much of the research in transgender health, other than the HIV care research, is based on clinical consensus. So all of the chapters in this, in the new Standards of Care will be graded, and we've sent out a call to an open call for evidence-based medicine teams to apply to be the graders and the reviewers of the evidence and provide direction and writing. And then the people that are the chairs of the chapters will provide the questions in terms of for which the evidence-based medicine teams can research. Finally, the project that we have started as of late in the last 2 years is called the Global Education Initiative. And we had a strategic plan in terms of our, we have 4 main goals in our strategic plan that runs from 2013 to 2017. And one of our strategic goals is to educate and to train. And so we have started our Global Education Initiative, and our main purpose is to improve access to care for transgender and gender non-conforming people worldwide. And this coursework is based on the standards of care. So the co-chairs for this are myself and Dr. Lynn Fraser, and we started with pilot courses in Chicago in November 2015, and we've hosted 14 courses since then. And as we speak, we're developing online courses, because what we want to do is have free online courses for people globally through our website that provide an introduction to transgender health care. So we've had 2 phases of development. One is competency development, and the second is a train the trainer. So when we looked at competency development, we invited people at a previous Trans Health conference that WPATH sponsored in Bangkok to come together. And we said, okay, so you people are the are leading people in the world in terms of clinical work, academic work, legal work. If you were to look at if we were to provide courses, what 4 areas would you want us to focus on? And so, so these were the 4 areas that actually came out: social, psychological, medical, and legal. And so these are these are part of the content, and these are also part of that went in the gender affirmation leaflet that is in the Lancet series. The competency domains, these are the domains that we're using. And again, what we did for this to develop these domains was to ask education experts from different areas of the globe working in transgender health, and these are the domains that we are going to map to. So finally, there was a Lancet series that was released last June, and just done. That was released last June, and there are several of the authors here. Steph Baral is up front, Tanya's here. And so this series highlighted the need for transgender healthcare globally, and also highlighted the need for primary care, and that primary care clinicians are going to be the main drivers in terms of transgender health globally. And so what we've done is develop training courses in the US. We've had one in the Netherlands, one in Japan, and we're having courses in Latin America. And so we're doing a train the trainer model in that we're invited to different countries in terms of learning about what the trans health system is like in their country, adding the content related to the standards of care, and then adapting that content, and then doing a train the trainer kind of model. So we're really interested in partnering with you in education and training. And if you are interested, I would ask you to please contact us. Donna Kelly, who is our Executive Director of the Global Education Initiative, or me. And I would love to hear from you. I would love to partner with you in terms of education and training. And thank you for inviting me to speak on behalf of WPATH, and thank you for your time.
Thank you very much. Thank you very much, Dr. Knudsen. And I think we will move to the next speaker, and then we'll keep the questions at the end of the session. It's getting warmer here, probably not because of the speaker and the content, but because of the malfunction of the AC here. So please feel free to use your sheets to cool yourself down. Okay, our next speaker is Dr. Asa Radix. Dr. Asa is clinician, educator, and researcher whose main area of expertise is in transgender health. Dr. Asa is currently the Senior Director of Research and Education at the Colin Lord Community Health Center and an Associate Clinical Professor of Medicine at New York University. After finishing their undergraduate medical education in the West Indies, Dr. Asa completed further training in internal medicine, infectious diseases, and public health at the University of Connecticut. Dr. Asa has published widely in the field of transgender health and has assisted in developing national and international guidelines in transgender medicine. The presentation title will be Gender-Affirming Hormones and ART, Implications on Adherence and Clinical Outcomes. Dr. Asa, please.
Thank you. Again, I'd like to thank everyone who's spoken before me. You've kind of done my job. Thank you. And for the invitation to present here. So I don't have any conflicts of interest. What I'm going to talk to you about today is I really wanted to answer a few questions. So we're going to talk about, what are gender-affirming medical interventions? and what is the impact that provision of hormones has on HIV prevention, treatment, and care, and what are the additional considerations that exist for the use of hormone therapy with ART. So just a little about, gender-affirming medical treatments. Not all trans people undergo medical or surgical interventions, but these are a few of the things that are on offer. So hormone therapy, androgen blockers, I should probably also put puberty blockers in here, different surgeries, speech therapy to change the pitch and tone of the voice, and hair removal. That's usually, hair removal from the face for trans women, from the genitals, like before you have lower surgery done. There are many aspects of medical transition for those who wish to go through, and I put here an extensive list of surgical procedures that are done. I mean, today we're really going to confine our discussion to the hormone treatments, but I wanted you to see that there's quite a lot, and this is the reason why we don't talk about having, the surgery, because there's so many different procedures that people may undergo. There are a lot of people who think that, gender-affirming care just happened maybe in the last few years. And I think it's important to remember that this is really, we're talking many, many, many years. And in fact, in the early literature, these are some of the first hormones that were developed in the 1930s and 40s. And almost immediately, as soon as these were synthesized, they were starting to be used for gender-affirming care. Actually, none of these, a few may still be used, conjugated estrogens and ethinyl estradiol. But for the most part, these aren't used in the current modern treatment of gender dysphoria. So I wanted also to put up, for those of you who are from many different countries, there are so many guidelines that are out there, both international, regional guidelines. You heard a lot today about the standards of care. Many of the other guidelines are actually based on the standards of care and just adapted to regional contexts. So when we think about the regimens that we're using, for trans women who decide to go on feminizing regimens, there are many different types of estrogens that are currently used. So we use tablets, we use injectable, you can use patches, there are gels available in some countries, there are depots that can be used. For androgen blockers, usually when people are on estrogens, you need to block testosterone if you still have gonads or still have testes. So in different countries, there are different regimens. So spironolactone is one that's used, also finasteride, sapropteron. There are also gonadotropin-releasing hormone analogs that are also used in some countries. I think you'll be hearing a little bit later from Tanya, but I think all these different regimens does make it a little difficult sometimes when you're going forward with research. Generally, we start at the starting dose, the lowest dose, and generally these doses are titrated over the first month that someone's in care, first month to 2 months to the average dose. So what do feminizing regimens do? Well, they change your body shape. So for transgender women, you'll have breast development. You'll have movement of fat, so you'll develop, hips. And you'll have some changes also in body hair, usually not facial hair. So if you've developed facial hair, that will generally need to be removed. Erectile function decreases. You'll see lower sperm count. So we do discuss this with people who wish to have genetic offspring. For transmasculine people who opt for hormones, there are masculinizing regimens. It's generally different types of testosterone. So there are many different types. There's injectable, there's gels, there's patches, there's long-acting testosterone that only needs to be given every 10 to 12 weeks. So generally the discussion about which one you use depends on the country that you're in, what formulary is available, and also the preference of the client. As far as the regimens go, they generally all do the same thing. They pretty much follow the same timeline, no matter what type of testosterone you're getting. So usually the first thing that happens, is people will start to notice changes in their body shape, increase in muscle mass, the menstrual cycle will stop, but also facial and body hair, in a typical male pattern. The voice will get deep. Some will develop loss of hair, so male pattern baldness or androgenetic hair loss. And the clitoris enlarges. And the one thing that is probably important for HIV prevention issues is that you do develop atrophic vaginitis as well. So what about other things? I mean, besides the obvious physical changes, there are also many psychological changes that happen on hormones, and they're all really great and positive. So we've seen studies that show improvement in quality of life, that people who can access hormones have less stress, less anxiety, less depression, definite improvements in social functioning, sexual function, and there are even some physiological changes. There's some early research that's showing that when people initiate hormones, there are reductions in early awakening cortisol levels. And so I think that's really, really interesting. Of course, there are other effects too, and I believe that Tony will talk a little bit about that later. So thinking about antiretrovirals and hormone therapy, what do we know about regimens and viral suppression among trans women? You heard a little bit about this already from Arent, but we know that women who are HIV infected are less likely to receive antiretroviral therapy. There's work from Rita Melendez and Jay Sebelius about that. More likely to report lower adherence, and as you heard already, that are more likely to have detectable viral loads. And there's even evidence that there's a higher HIV-related mortality among transgender women. And in San Francisco, they accounted for about 2% of people living with HIV, but about 7% of deaths related to HIV. Also, when we look at prevention, there are lower rates of PrEP uptake and lower adherence to PrEP, and we saw that work from Maddie Deutsch and Bob Grant. So definitely there are some concerns here about why is this happening? Why is there this disparity in use of antiretrovirals, whether for treatment or for prevention? There's also here data from the Ryan White HIV/AIDS program. This also, this is a program that takes care of well over 500,000 people, and about just over 1% of those are people of trans experience. And when we look at the data, it shows that people are retained in care, but still there's this disparity in viral suppression, particularly among transgender women, and even more so among transgender women of color, specifically African American women. So looking at these disparities, I think it's useful to think about why is this? So why are women less likely to engage in care or adhere to care? And, we have a few answers from the research, which shows that, women are more likely to, prioritize their medical transition care over HIV care. And if people have to choose, like if they have to get HIV care in one place and they're getting hormone care in another, they're going to prioritize. If they can only get to one appointment, probably keeping the one that's giving them hormones and gender-related care. There's been some research that women are concerned about drug interactions between HIV medications and their hormones. Definitely nice work coming out of the West Coast and Jay Sebelius showing that women often have difficulty integrating HIV treatment into their daily routine. There are also stories about negative experiences with medical providers and health systems, walking in and being misgendered, people using a name that you don't wish to use. That really keeps people out of care. And, fear of stigma and discrimination, I think we have a lot of research showing that, well over 50% of trans folk have experienced discrimination in healthcare settings. So all of these things are reasons why people aren't in care. But I wanted to specifically talk about, the fears about drug interactions with hormones and HIV medications, which, we did a look back, and this is work that's been done by many people, but I think one of the issues is that we don't have good research in this area. Most of the data that we have that look at interactions between hormones, and specifically estrogens and antiretroviral therapy, has come from work done with oral contraceptives ethinyl estradiol. Women who are using hormones for transition use very high doses of estrogens, and I think it's important that we learn a lot more about potential interactions. We know that estrogens are metabolized by the cytochrome P450 system, specifically CYP3A4, and also that, for example, protease inhibitors are CYP3A4 inhibitors. So we're concerned about interactions. The good news is that there really aren't worries of reduced efficacy of the antiretrovirals at any time, other than possibly with fosamaprevir, because it can reduce the concentrations of the drug if you're using estrogens. But other than that, we're generally not worried about being able to maintain viral suppression. When we did a look back of all the agents that have been used for HIV care and whether or not there were interactions with estrogens, we found, there are basically two areas to be concerned about. One is if you are using unboosted protease inhibitors, you can get an elevation of estrogen levels. So in situations like that, if you can measure levels, measure, and you might have to decrease the dose of the estrogens. If you are using boosted proteases or combinations that include cobicistat, these tend to reduce or drop estradiol levels. So in that situation, you might want to check the level and increase the estrogen dose. Women who've been on hormones are very sensitive to changes in the doses, especially if they've undergone gonadectomy or an orchiectomy, because they know they may have hot flashes, they may feel uncomfortable. As far as the other medications like the integrase inhibitors, there really aren't any drug-drug interactions to be concerned about. We know that access to hormones improves engagement for women. It's been cited as a primary motivator for seeking medical care. Women will come to appointments where hormones are being delivered. Nice work again from Jay, who seems to be doing a lot of the work here, that when women are adherent to hormone therapy, they tend to also to be adherent to the antiretrovirals. And we use that in a very simple way. If someone's on a once-a-day regimen, I usually have them take the estrogens and blockers once a day. If they're on a twice-a-day antiretroviral regimen, we'll split their hormone doses. It's just a nice, easy way of, like, we know that you're going to take these. Also, as you heard before, when hormone providers hormone is prescribed by HIV providers, that also improves antiretroviral adherence. And Arent spoke about that earlier. So just a little diagram here. So, we have factors that we know improve engagement and viral suppression, and we know we have factors that lessen, right? So the few things, integrating hormones into HIV care, providing a gender-affirming environment, giving information to our clients about the fact that there aren't drug-drug interactions to worry about, and we're going to be checking your levels, and we'll make adjustments, and I think that hearing that is super important. Competent providers and health systems and training staff and including people of trans experience in your centers is again very important to improving engagement. So. I think this is my last slide. So just like a few tips to take away. We've heard a lot today already about co-location of services, but training providers, again, GEI and WPATH, I think there's some excellent resources out there. There are also webinars, free resources. I think that's super important. Talking to clients, having trans-inclusive materials. I don't know if any of you noticed the great pictures that were in my presentation. We've actually, couldn't find pictures of people of trans experience that were happy and available. So we had people come into our center and we said, we'll take pictures of you with a professional photographer, and we'll have someone doing stylist and makeup artist, and we'll give you a portfolio. Can we use your images? And it was very successful. So we've had to make our own, but there are more trans-inclusive materials available every day. This Take Pride, Take Care is from the New York City Department of Health. and of course hiring people of trans experience. These are all steps that you can take to improving retention, engagement, and adherence. Thank you.
Thank you so much, Dr. Asa, for showing us such an important data. For us as healthcare providers, it's very important to think about this issue. It's important to use the correct drug and in correct dose, not only in HIV cases, but because of the risk of cardiovascular diseases and another risk. It's very important to think about the social issues too. We have to think about it all. So it's my pleasure to introduce our first, but not less important speaker, Dr. Tanya Petits. Dr. Tanya Petits.
That's all.
Dr. Tanya Petits is an assistant professor in the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health. She completed her PhD in International Health at Johns Hopkins. She holds an undergraduate degree in biology from Yale University, a Master of Medical Science from Emory University, and a Master of Public Health from Rollins School of Public Health. Her research, teaching, and clinical practice focus on HIV and LGBT health with particular attention to transgender health disparities. Dr. Petits is a certified HIV specialist by the American Academy of HIV Medicine and currently provides medical care for people living with HIV at Johns Hopkins Hospital. Her presentation entitled Connecting Trans HIV Clinical Care and Research, Using Cross-Cohort Analysis to Identify Long-Term Complications. Please, Dr. Tanya.
Thank you. I also just got a free iPhone.
That's mine.
Okay, I guess I can't keep it. It's very warm, and I'm looking forward to our conversation, so I'm going to try to make my comments brief and build on what my really fabulous and brilliant colleagues have already said. I do have a disclosure that you can read there. As Dr. Petits was saying, there is evidence of limited engagement in HIV-related care by trans populations, and this is data from the same set of data from Ryan White in the United States, one of the largest providers of HIV care. And you can see that there are disparities in engagement towards the end of the care cascade. And so what I want to talk to you about was, what does that mean? So we know if there's lack of engagement, then there's worry about lack of viral suppression and opportunistic infections. But also lack of engagement in care means that people aren't getting monitored and screened for other comorbidities. And I want to talk a little bit more about what we actually don't know, but what we could know if we use data that we might already have access to. So we know that among people living with HIV that there are disparities comparing people with HIV to people who don't have HIV in terms of mental health, substance use, concerns about chronic inflammation, and cardiovascular disease. We also see very similar comorbidities among people of trans experience, of any HIV status. So what might that mean? And I'm going to focus on cardiovascular disease risk, not only because that was mentioned by one of the moderators, but because I think it is an issue that's been underappreciated over time and that I hope to be focusing more on in the future. So what is the pathway to increase cardiovascular disease risk among trans people living with HIV? We know that HIV is associated with increased cardiovascular disease risk, and there's an entire study going on called the REPRIEVE study looking at that and how to interrupt that. It's multifactorial, including both traditional risk factors like smoking, lipids, diabetes, as well as some particular antiretroviral agents that are associated with increased cardiovascular disease risk and chronic inflammation. And there's lots of research going on looking at various biomarkers and what might be associated with increased cardiovascular disease risk among people living with HIV. We also know that exogenous estrogens are associated with elevated cardiovascular disease risk. We know this from studies with cisgender women, and we know this from studies with transgender women. What there's controversy about is whether exogenous testosterone affects cardiovascular disease risk. There's been conflicting studies looking at cisgender men as to whether or not testosterone is protective or whether it increases risk, and I think the jury might still be out on that. And there is very little data among transgender men altogether. I was able to find 2 studies, and both of them didn't see any increased risk, but those were small studies and certainly not longitudinal, the type of longitudinal studies that we need. We also know that soft tissue filler use, although we haven't talked about that much today, is very common. People often call it silicone injections, but frequently silicone injections are adulterated with other things, commonly used by transgender women for feminization of the body. And they can also be associated with chronic inflammation. So you can think about that in the context of a trans woman living with HIV. And we know that chronic inflammation can be associated with cardiovascular disease as well as HIV disease progression among people living with HIV. So all of those things raise the question of what do we do and what do we know in terms of cardiovascular disease risk and other comorbidities among trans people living with HIV? And my question is, how can we efficiently gather this data among trans people living with HIV? And I say efficiently because I feel like we've been waiting a really long time, and we're finally at a point where people are paying more and more attention to transgender health issues, and it's a prime opportunity. And there's also actually data that we keep finding buried in data in other studies among transgender people that if we're able to pull that data out, we can have access relatively quickly without needing to build and create longitudinal studies, which of course we need to do, but we can build on the information that we already have. HIV clinical cohorts presents a really important opportunity to do that. Clinical cohort studies are designed to monitor clinical outcomes over time, typically in real-life settings and real clinics where people are getting care. They offer opportunities for clinical breakthroughs. For example, the validation of viral load is a marker of disease progressions, which seems like a no-brainer to us now, but was actually information that was drawn from clinical cohort studies. Discovery of HIV co-receptors was also data that was originally drawn from clinical cohort studies. So those are great opportunities to learn from data that we're already collecting in clinical environments. There are multiple existing HIV cohorts that include clinical sites. The International Epidemiology Database to Evaluate AIDS is one idea. People might be familiar with that. They have a Caribbean clinical cohort collaboration as part of that, and a North American one, as well as several others. I'm going to focus on the North American AIDS clinical cohort on research and design, abbreviated as the NA Accord. The NA Accord is the largest HIV cohort collaboration in North America. It includes sites in Canada and the US. They have 25, I think it's actually up to 30 contributing cohorts at this point. This is a little bit dated in terms of a picture. Over 200 study sites and contribute data on over 150,000 people living with HIV. Unfortunately, up until recently, the reporting criteria did not identify transgender participants. And in fact, they were explicitly, the sites were told not to report data on transgender people, even if they collected it. So some colleagues and I went back and we wanted to talk to the principal investigators of the clinical cohort sites to ask them several questions. Do you have data on transgender people at your clinical site? How many do you estimate transgender clients or patients do you have at your clinical site? And would you be willing to report that data to NA Record if it was required and participate in trans-specific studies? We also asked them how did they collect that data? And so what we found is that the method of data collection was really not standardized across sites. So some site had a place in the EMR where they asked everybody their gender identity and they were able to identify transgender patients that way. Other sites, they looked at their medication record and if they're sex assigned at birth, say was male, and then they were on an estrogen, then they were identified as transgender. Other places, there was a DSM or ICD-9 criteria. So you can see there was a plethora of ways and nothing was really standardized. On the brighter side, 88% of the PIs that we talked to were willing to collect data on transgender status, whether or not they did right at that moment. And they gave us a general estimate of the 11 clinical cohorts that we were able to talk to of about 569 transgender potential participants. And the vast majority of those were trans women with only two trans men identified. And this represented just under 1% of people living with HIV under study in these 11 cohorts. So we felt like it was feasible and acceptable to do trans-specific cohort studies within existing cohort infrastructures. The implications of what we found is that there were a small number of trans participants at each site, so pooling across cohorts was going to be necessary in order to have adequate sample sizes to do research. That standardized data collection methodology was needed so that we made sure we were comparing apples to apples and oranges to oranges. But that a multinational trans HIV cohort collaboration could be established building on those existing cohorts. So the next step was to do that. So we just recently established the NA track, so the North American Transgender AIDS Cohort Collaboration. It was formed within the NA Accord using a standardized definition for transgender based on the two-step model at the University of California, San Francisco, which distinguishes between the sex assigned at birth and the person's current gender identity. The first cohorts reported their transgender identified data this year, actually just weeks ago, hot off the presses. 10 of the 17 clinical cohorts that participated have contributed data in this round of data collection. I am hopeful that people will be inspired by their colleagues and more will contribute as the project continues. And our very first steps are going to be to answer basic clinical questions about the HIV care continuum and prevalence of comorbidities, information that we actually don't have on transgender people living with HIV right now. And up to today, I think about a week ago, we had 258 transgender participants identified within the NA Accord clinical cohort collaboration. So in the future, what we hope to do is collect medical record data on estrogen and testosterone prescriptions. So we're in the process now of figuring out how to code and extract that data, which is a challenge that is harder than you think. We want to collect patient-reported data on the type and duration of gender-affirming hormone use and history of silicone injections, so things that are unlikely to be in the medical record. So physicians don't typically prescribe, or other providers prescribe silicone injections. Those are typically illicit. And there are some people who get their hormones outside of a formal medical sector. So we want to be able to get that information as well as we look at the effect on long-term health of trans people living with HIV. And we want to assess relationships between exposure to exogenous sex hormones and or silicone and cardiovascular disease risk. And we also want to take a look at the effect of soft tissue fillers on inflammation and disease progression among people living with HIV. So I believe that NA Track can be a model for other cohorts within IDEA, offering an example of how to identify trans patients in this data set in a standardized way and collect data that's relevant to trans health and gender-affirming care. And that's all I have to say, because I want to hear your questions. And I'd like to thank all of the fabulous people at NA Accord. And here are my citations. Thank you. I was going to leave somebody an Android and an iPhone.
Thank you very much for the wonderful presentations from all of our speakers here. I think we are now open for the questions from the floor. We have 27 minutes from now. Yeah. So yeah, please line up on the microphone. There are 4 microphones in this room. Let's start by introducing yourself and also identify which speaker you would like to have your questions for. The gentleman on the right side, please.
Hi, good morning. My name is Peach and I'm from the Thai Red Cross AIDS Research Center in Bangkok, Thailand. So my question is actually directly toward Dr. Wilson. Like Dr. Radix has mentioned in her presentation, that a lot of the TG population prioritizes hormone services over HIV testing. So I'm wondering what have the 9 centers in San Francisco been doing if you have integrated HIV services and STI services into the hormone services. And so that's my first question. And the second question is that what are some of the activities to retain these TG populations in the care that those centers provide? Thank you.
So each site, again, there are 9 different sites. They're all very different, but by and far, there were a number of clinical sites and then social service sites. So half of them were, like this clinic I worked with in the East Bay was a long-standing trans-specific clinic. They've been providing trans-specific care for 15 years. They're also a HIV care clinic. And they have a number of social services and case management services already integrated into what they do. So the idea for these initiatives was really to layer something on top of that. So what this particular clinic did was they layered on workshops that were trans health oriented, but they included everything from self-defense to legal rights to everything that a person might be interested in. History, we did this amazing piece where we put trans history all along the walls of our big rooms in the clinic. And then we also had our legal clinic. So So most of these sites were already well-integrated sites with a long history of providing trans-specific care and HIV care to their clients. And so the trick was layering that additional piece on top of it. And a lot of that, we didn't plan for that to be a retention activity, but it ended up being that. So we had these workshops, and people were incentivized to come in to attend the workshops, and then they could graduate. And as part of getting them in on a weekly basis for the workshops, then we could always remind them about their HIV care or trans health care visits. And so we also, the research ended up being a really important piece of the retention, because we had to collect data with them as well, collect patient surveys. The site I worked with actually got in their car and drove to people's houses, met them in Oakland, met them on the street, wherever they could, to collect the data. And that ended up being a retention activity. And this really resonates with me in our HIV epidemiology studies. We have a lot of retention efforts too, and it's about constant contact. We have a lot of folks in secret Facebook groups. We chat with them, we send them birthday cards, we invite them to events, we invite them to speak, we try to engage them on a regular basis as much as possible in between visits. And that's what a lot of these sites did. Both the research and the interventions kept them engaged.
Hello. My name is Manisa Thakal. I'm a transgender activist from Nepal. First of all, I'd like to thank all the panelists for your wonderful presentation. And during the presentation from the Dr. Gale and Dr. Arent, both agree that the hormone is the primary motivators for seeking medical service and retention of the HIV care services. I want to link in Nepal that medical doctors and medical service are good enough for provide the HIV services for the transgender people, but the lacking thing is there is no any services for the hormonal treatment and the transition. So my question is, Gail, how WPATH help the doctors and the medical service providers in the country lag behind country like Nepal to provide the service for the transgender? And also I'd like to urge the Global Fund and FHI linkage program. They are now investing the HIV services for testing only. There is no any services for this kind of transgender healthcare service. So I'd like to urge Global Fund and FHI linkages program to invest the money for the transgender health clinic that helps to retention for the service for HIV also. So my question is for the Gail, how WPATH help the country like Nepal to provide the information training for the doctors for the transgender?
Thank you. Well, the first thing would be to contact me at WPATH. Were you able to write down my email? And then what we would do is set up a program to work with healthcare providers in Nepal, and also to figure out what would be the best way to approach the training. So when we had a meeting of different kinds of healthcare providers and activists and advocates last year in Amsterdam, it was about meeting with people that are in the community there, and to say, what is the best way for us to come in and provide training? Is it to engage at a governmental level and then to help with the policies and to help that way, and then have the training come from that direction? Or is it better to engage with a grassroots organization or an NGO and try to come in that way to provide the training? So can you contact me, and then we can talk about that further?
Okay, sure.
Great.
Thank you.
Thank you.
Hello. Thank you very much. My name is Michael Oligodaro with AVAC in New York. Thanks for the great panel. This was really great to be here. I have a question, or more of a comment to Dr. Gill and everyone else in the panel. I was just wondering, I assume you guys were referencing challenges in access to care, and also referencing around hormones being the key point of transgender people wanting to get care. But in the past year or two, I've been working with transgender individuals and organizations in Africa, and as you know, there are a lot of them now. But one of the things that we've noticed that for them, hormones is not a thing. It's really about, documenting their abuses and challenges that they see. It's the biggest challenge for them. The government don't provide hormones. They don't care too much about HIV. What they really care about is their safety and being safe at home and at the offices or being most of them are sex workers too. So we are trying to see how we can make HIV an issue for them to look at, because I feel like they are being counted as MSM. And as a gay man myself, I know it's not fair to them to be counted as MSM because they are not MSM. So I'm just wondering, for Africa, right now we have a lot of transgender organizations in Kenya, in Zambia, in Uganda. A lot of them, those 3 countries right now, they have like at least five transgender organizations there. And I'm wondering, in the coming months or so, we're trying to organize prevention research, a meeting to identify research priorities for transgender population in Africa. And I'm wondering if you have any advice for us or comments for us, or what we should be looking at and how to work with this population, because I'm not transgender, but I just feel like it's an important issue. But on the global level, people don't just think about Africa, like there are trans people in Africa, and we should also, look into their issues. Thanks.
I'm just going to make one comment, and then I'll ask Tanya if she can comment. That really speaks to, thank you for your comments. That really speaks to that grid that I had on, that came from the Lancet paper. And that when the people globally were talking about, well, how can we, improve access to care for transgender people globally? And in that case, it seems like what you're talking about, if I have it correct, is it's about that legal documentation and all the social aspects of social transition. So I think it's how WPATH can work with the governments in that area to see if there's anything that we can do to move that.
Are there any guidelines in terms of providing services for transgender population, like in terms of HIV?
Yeah.
Yeah.
Tanya.
Yes. You have here probably many of the, I don't know if this is on or not. Can you hear me?
Yes.
Okay, many of the authors of the comprehensive HIV I thought you were waving it. I was going to get excited.
I know the transit. But
Yeah,
in terms,
so
I know that very well. But I just feel like, I don't know how that can be in a way. I know the WHO implementation tools and stuff, and transit is all there available. And sometimes it's not that useful for me, and for populations that are in this sense of them, they are. Do I put it now? HIV again, it's not as a priority for them. And that is not identified in that tool.
Yes. So I would like to respond to your original question, not the booklets we have, right? So the question is, how do you respond to the real expressed needs of people on the ground? That's what I hear you asking. And if worries about violence and stigma and discrimination are primary, then those have to be addressed. And I think at the Key Populations talk yesterday, there was a lot of discussion about integrating that into any service that you're attempting to provide. And I don't know if people are familiar with something called the Maslow's hierarchy of needs, but in terms of seeking medical care, that's going to be much lower if you're worried that somebody's going to kill you when you walk out of your house. And we see that in Baltimore, and I think you see that around the world. So addressing that is going to be essential to providing any other services. And there are grassroots trans-led organizations in Africa. I'm thinking of Leanne Vandermeer's organization, She, that's based in
Africa?
Yeah, in South Africa. So that might be a good person to partner with. And then there's other leaders in the room and funders in the room that I recommend talking to about addressing the issues that are a primary concern to people that serve as barriers to even thinking about HIV, much less actually engaging in prevention and care.
Hi, I'm Inês Dourado from School of Public Health in Northeast Brazil. Great session. I wanted to hear from both Tanya and Asa your comments on industrial silicon and on building the collaboration on these cohorts, because you mentioned, Tanya, of silicon fillers, and it's not clear for me if you're including or industrial silicon when you mentioned that, because in Latin America, and specifically in Brazil, it's such a big issue. And it's such a big hazard for trans population. So I would like to hear from you both, or from Arent as well.
Yeah, I mean, I work in a clinic in New York City, and we have about 4,500 people of trans experience. I think we are the largest clinic anywhere, and about 20% of one in five of the women we see have used fillers, right? And they're generally not in surgical grade. They generally are industrial silicone fillers. We've seen people having all kinds of things injected. I mean, we've had someone at one client with peanut butter injected into the breast. I think that the issue here, though, is really one around access to care. People will not resort to injecting fillers if there are safer alternatives. One, people often aren't so familiar with possible side effects until they've had a side effect themselves or a friend has. I think that's the first thing. But the real issue is around education. So we've been doing a lot of education around the hazards of fillers and hoping that it spreads throughout the community, that, if you have options like hormone therapy or, breast implants, I mean, you can achieve a breast. But of course, these things cost money, and it can be very, very difficult. Yeah. Did you have?
I think that's such an important question, Inez. I think this is tricky because in the States, like in San Francisco, we have this perfect paradigm where we have HIV care, we have trans-specific care, we have a pilot program for surgeries that people can access. That's not going to happen in other countries. So what do we do, I think, is the question. And we've been struggling with that a lot. I think, I've lost numerous participants to fillers, so toxic reactions where they died. It breaks my heart. And what they need when they come in and can't walk because their fillers have migrated to the bottom of their feet and everything hurts so much that they can't move. The first step is really treatment protocols, and this is something I've really struggled with. It's hard to find physicians that know what to do when somebody's had a reaction or has fillers and is having problems. So all you doctors out there, we need as many protocols as possible as to how to actually treat and address symptoms related to fillers. And I think we need to understand that folks aren't going to have access to breast augmentation surgery. So what do we do in the interim? How do we serve people better? I think we need treatment, but I don't know what the answer is for folks who don't have access.
Thank you.
Hi, my name is Teresa Gamble. I work for FHI 360, and I'm part of the HIV Prevention Trials Network. I have a question about integrating transgendered people into research. So I feel like on my studies we've gotten some conflicting guidance. We have a particular study that I'm thinking where we were told we should not include them. It was an MSM study because they want their own study. And then when we started, we found so many that we changed the protocol to include them. But now there's not so many being enrolled, so I'm not sure we can do the sub-analysis. So any kind of advice or guidance, I would really appreciate it. Thank you.
I'll take that hot button question. No, I think it is really a challenge, right? Ideally, studies would be designed and tailored for trans people because they have specific needs, both around recruitment and engagement in study protocols. At the same time, there are limited resources and limited access. And so if you have a study that's rolling out that's relevant to trans communities, excluding them is also not the best answer, as you learned. So if there's a way to make a study that is for more than one population, so not have an MSM study where you include trans women, for example, but have a study that's for two different populations that you're enrolling, and then do the active recruitment and engagement so that people aren't giving their data in vain. I think that's really frustrating for communities too, to say that you're open and then you enroll 2 or 3 people and then it's not enough to do a sub-analysis. So I'm not saying anything you didn't just say to me, but it is a real issue. And I think thinking through it and involving community from the beginning of the study to talk through these issues, and when you're doing community engagement, is going to be really, really critical. Moving and learning from the lessons that I think we're all continuing to learn. I don't know if you wanted to add anything.
I mean, I just add that I think like nuts and bolts, I think you're saying exactly what's right. There are a lot of communities around the world that don't see themselves as entirely separate from the MSM community. And so I think you have to be context specific. What does it look like in Jamaica? What does it look like in Namibia? What does it look like in each and every country? And some places folks would not be offended by being included with their MSM brothers. But the community engagement piece is really important, but I think the nuts and bolts of it is you do have to specify this is a 2-population study, and we are going to meet the sample size on this side and on this side as well, and not just hope trans women come in and participate, but really commit to achieving a sample size that will give you enough data to do a rigorous analysis.
I think we will take 4 more questions from the 2 people on each side of the room. Beatrice, please.
Yeah, thank you for the great panel. I have questions to Tanya and to Arent. Tanya, related to database data collection, we are a large care provider in Rio de Janeiro, Brazil, and we are struggling to put together our database for the transgender cohort. So we are going back, doing our archaeological work back to the 80s when we started to provide care, and since the beginning we provided care for transgender women. So going back, we are struggling with analyzing each chart to have it the most comprehensive possible. And now we are facing 2 issues that I wanted to hear your opinion. First, when our transgender women get the legal names, they change the birth certificate. And so they are now they are considered women from birth. How to deal with this with regards to the database? The second question is, we are also seeing people who are transitioning back. So how are you dealing with this in your database, and how do you envision this dynamic issue about going forward and back with gender transition? And to Arent, I would like to hear a bit about your experience with your trans PrEP study and how it's coming along. Thank you.
No, I would.
Go ahead.
We're both going to answer, because we had the specifics, the same issue in our clinic when we were trying to identify people, and we used it was a 5-point system for when people had their sex assigned at birth changed. So we looked at medication use. For example, a lot of the women in the US use spironolactone for transition purposes. So if you were able to pick up spironolactone in a record, that was a way to know you had to look a little bit further. We also were able to look at templates for examinations. For example, if you have an examination and the person has a penis, when you're evaluating, you know no matter what their sex assigned at birth is written down as, it was not female, right? It was changed. So we were able to identify people from that standpoint as well. So combination of prescriptions, anatomic surveys, and anywhere in the records, if there was a name or gender mismatch, because if people changed their names, we also had records of that the names were changed. We were able to look at that. So these were just a few of the ways we were able to go. We were able to actually identify an additional 30% more people. Yeah, you can go ahead.
Okay. Well, I think that's great. I was going to speak to, there are algorithms that people have developed. I didn't know that Callan Lord had developed one, but also Michael Goodman at Emory University used one to go through the Kaiser database and identify people. And at the clinic where I used to work, we actually had a registry, which was challenging because people had to put people's names in the registry in the electronic medical record, but that meant that once they were in the registry, you could pull out those specific people without having to constantly search and go back and forth over time. So that's a good moving forward. But I think you're going to have to use some of these algorithms that are in place that you've already probably been doing that's painful and excruciating, and you called it archaeology because it really is. And then moving forward to be able to track people in a registry or some other way.
I just want to say on the idea of the term, hi Beatrice, the idea of this like desisting or turning back, we've struggled with that in research. We have had a lot of participants that present one way one day and different another day, or somewhere along the course they say, I don't want to be involved because I don't think I'm relevant for this study anymore. But our experience observing them over time is really the reason they aren't not able to live as who they are is really due to violence and discrimination and access to care. So we've never dropped anybody because they've told us they no longer identify, because we've been able to talk to them about why. So this idea of folks turning back, in my experience, it's never been because that's not who they are. So we try to include them and keep them in our studies as much as possible. Oh, PrEP. We're just rolling out. We have this amazing PrEP study. It's a 4-clinic study in San Francisco. It was funded by the state, the UC Regents, specifically to roll out PrEP specifically to the trans community. We're super excited. We just started rolling out the study. We have these amazing materials and a website, and I have the link that's attached my name in the front of the presentation and one of our pieces of advertising as well. But we're very, very excited, and people in the trans community are very excited. It's a good time. There's a lot of knowledge about persistence and what adherence challenges are, and so I think we're going to hopefully be able to address a lot of those and see some great results. So TBD.
Thank you. May I please take 2 questions from that side and then ask you to answer, and then another 2 from this side?
Good morning. My name is Maria Amélia Veras. I'm from São Paulo, Brazil, and I've been working with transgender people. And I'd like to say this is the best session I could ever attend. And I have so many questions, and I could share with you so many data about our own research, but issues that are related to the context, the social context in which Brazil is unfortunately a champion in terms of violence and discrimination against the transgender population, but also the hopes that we are facing in Brazil now with so many data, new research protocols, and new engagement of health professionals trying to learn a little more on how to deal with the transgender population. So we have a huge gap to go, but I just would like to share with you 2 informations from our own data in the state of São Paulo. The first of all is when the trans population reach the healthcare settings, they are already transforming. They are already pursuing body transformation through different things. So Inês comment on industrial silicone filling. We have data from São Paulo that most of 50% of our sample of 700 had already filled silicone in several parts of the body. From those who filled silicone, half of them had health adverse effects. And even though they are satisfied with the effect of the silicone in their bodies. So they would do it again. Of course, because they don't see any alternative, safe alternative provided in the health system at all. The second is the hormones. We have a poster that maybe Luca will comment on that, showing how the same thing. At the age of 18, they already had started hormones, and when they come, they already had used it in several different ways. As an outcome, we've been hearing almost every week about a trans woman dying with heart attack. And we don't have official data to know how much, because in the death certificate, most of them are registered still as the gender assigned at birth, the sex assigned at birth. So we have a huge problem. I was thinking about and wonder if any of you would consider doing some protocol that we could share across the world, especially in places where we don't have good data, doing something like a verbal autopsy to try to reclassify and identify if those deaths could be related to the use of hormones. I'm not sure if it's too crazy, but I think we could do something in collaboration with several countries and maybe get some data regarding to those issues.
I think that's very doable. And nice to meet you in person. We were just contacting and talking on Skype. And I just wanted to advertise. Can you advertise your conference? Okay. So in the Brazilian team is going to be hosting the first Brazil Path meeting in São Paulo, November 1st to 4th. Would you like to say more?
Yes, that's, we are very excited about doing that. In spite of very short of funding and everything else, a group of crazy people in Brazil, a lot of physicians and epidemiologists and activists and trans activists, we decided to launch this. It's a huge need of training. I was speaking recently to 2,000 endocrinologists in the state of São Paulo, and they just don't know what to do. And they ask several questions because who are guiding them? Actually, the clients are guiding them. The trans people are arriving and they have more information than the physicians have regarding what to do with them. So we are now hardly working with several medical institutions, especially in the state of São Paulo, but not only, related to translate these guidelines, make it available, and engage everyone. And in the best spirit, the organization of the seminar is following the guide that nothing about us without us. So trans are in every single session, trans people. They are guiding, they are showing their research and their findings. So I think it will be a very important meeting, and we plan to go for Latin America path in the next year in Buenos Aires. Thank you.
Hi, I'm Christine Rael, postdoctoral research fellow at Columbia University, and this is more of a comment. I wanted to build off something that Dr. Radek said, and then later that Dr. Petits touched on, about how important it is to monitor hormone levels during the course of HIV treatment. I work on biomedical trials of some emerging products right now, and that is incredibly important during the course of this trials work as well. Number one, from a data standpoint, so that data can be available if and when these products go to market. And number two, from a recruitment and retention standpoint, if people know that we're going to be monitoring these very important things, they may be more willing to participate if they know that they can make decisions around their continued involvement around those data. And number two, when Dr. Petits was talking about how important it is to make trials personalized to particular groups, such as trans women, the SLAP HIV trial is one of the trials that I work on right now. And we are scheduled to do a phase 1 trial in year 5 of a cabotegravir implant. And right now my group is working on doing the legwork to make that trial as friendly and personalized to transgender women as humanly possible. So we've been doing groups, focus groups, we're doing a conjoint analysis. We'll likely be doing individual interviews again, hopefully soon after, to just make it as friendly as possible. So, and hopefully design some sort of methodological path that's replicable for other trials. So, thanks.
Hello, my name is Luca. I'm a medical student from São Paulo, Brazil. I'm also at Maria Amelia's study group. And I'm presenting a poster here at the AAS, presenting some results about what we found on unprescribed hormones among trans women in São Paulo, Brazil. And we did found that most of them use unprescribed hormones and not prescribed or medically supervised hormones, about 80%. And this was associated with being a sex worker, with being younger than the age limitation to be accepted in gender-affirming care, and also with travesti gender identity, a very specific gender identity we have in Brazil. I'd like to know if you have any idea of how to address those gaps among, those disparities among different trans women that are younger or that have this travesti gender identity, to reach them with services and things like that. And I'd also like to know something, because we found that most of the hormone users were using contraceptive formulations for their gender affirming care, and those included progesterone too. Is there any study that shows any adverse effects of ARV therapy and progesterone use?
So there's someone at the back who wants to answer that.
Please, a mic for her.
We're about to publish the results because I have to say that my colleague works in another hospital of Paris, and between the two of us, we have more or less 450 transgender women with HIV that we've been following up for the last 20 years. So we decided to conduct that project, which was very, very long because, of course, as you said, hormones are taken by not necessarily prescribed, and it's most of the time people can take hormones for 6 months, then stop and take a different type of hormone. So it was very, very difficult. But I don't know if I can reveal the secret of our results, but I can say from now on that there is no impact or interaction between, I mean, at least we don't see any difference between people taking PIs, PIs, and the other anti-retrovirus treatments, and there is no difference in terms of metabolic syndrome, and no difference with cardiovascular incidents or accidents. So that's what we showed, and we have many more results, but it's going to be published very soon. But we have a very large cohort. And the other thing I wanted to mention, I'm sorry, when you said that there was no other association in the world, well, in 2009 in France, we had an association which is called SOFECT, which is exactly on the same model of the American one. So, no, just to say.
Great, thank you.
And we have a large, huge cohort, almost 500 people now. That's
Thank you.
So I have just one comment. In Brazil, we have a specific issue because for us, because I am a transgender woman too, for us it's easier to get the hormones because despite of being of prescription medicines, we can get these medicines in pharmacies. But transgender men is more difficult to get the testosterone because testosterone is not over the label. We have to retain the receipt in the pharmacy. I am a pharmacist too, and it's a very hard situation. We have to think about this situation. It's a great problem in public health, and we have to think about transgender men. It's more difficult than to transgender women. It's very, very difficult for us in Brazil. But we are trying to solve this problem. We have a protocol of hormonotherapy in public consultant. I don't remember the site, but I can pass for the Brazilian ones here, okay?
Thank you very much, and yeah, thank you all the speakers and the audiences for the very interactive session today. I hope that all the information that we gathered today will help us reform or reframe our service delivery to our clients, and also, most importantly, I think every speaker points to the importance of engaging the trans communities into every aspects, even research or the clinical aspects. Thank you very much.